practitioner at Health Services, and Dr. Wendy Armenta. She's the psychiatrist. I'm sure you've seen both of them in our hallway. So,
Privileged to be in the hallway.
yes.
I thought we would start out just by telling you a little bit about ourselves, just so you know where we come from and just so you know we kind of know what we're talking about. I started almost 20 years ago, and my first experience was in a state psychiatric facility right out of my bachelor's program, and I was in charge of 18 to 30-year-olds who were pretty much schizophrenics, all schizophrenics, and they were sent up from the city of Metro North. They thought they were going for a little ride, and they came up and were put into a locked unit. So I was there for 3 years, and then I came to Benjamin Rush, which used to be a private inpatient psychiatric center, and I was in charge of the adult service unit and also the intensive care unit, which was a locked unit, the only locked unit. So in both facilities, we had obviously acute type patients who needed psychiatric care, and we were allowed at that time to do restraints and to do takedown and things like that. So at that point, we were doing that. I then went back and got my nurse practitioner here at SU and started doing some outpatient psychiatry and medication management. And that's what I've been doing ever since.
Hi, I'm Wendy Armenta. I trained here at SUNY, did my residency in psychiatry, which basically you do all kinds of different training in that, inpatient, outpatient, Hutchings. I don't know if you guys are aware of Hutchings, it's a state facility close by, University Hospital in the VA. And then I was hired right after my residency to stay on at Upstate, and I ran, well, two of us ran the inpatient unit at Upstate. So most of my training actually has been in psychiatric emergencies and inpatient treatment. So I did 6 years of inpatient treatment at University Hospital. Then I left for a part-time position at Community. I had 2 babies at the time. And I spent a year doing inpatient there, and then was recruited to go be the director of the inpatient unit at the VA hospital, where I spent, I think, 9 or 10 years, and I ran that unit. A lot of psychiatric emergencies there. About 2 years ago, I moved to an intensive outpatient treatment unit and pretty much dealt with all kinds, the sickest patients at the VA, basically. The whole purpose of that team was to have a group of social workers, me, and a couple nurses follow our most critical patients, ones with the most hospitalization. So I did that for about a year and a half, and then I was called by SU to take this job, which I just started in September. So, and Sherry just started in November, October. So we're both pretty new to SU and that part of things, but certainly not psychiatric emergencies.
So to get things started, we thought what we would do is show a little video about maybe some patients that you all have seen, and, oops, that's not the right one. And maybe some of the things not to say.
This is how not to treat a patient.
Thank God you guys are here. I am having really bad chest pain.
Really? Just like you were 2 hours ago? The last time you called?
2 hours ago, I was having difficulty breathing. I went to the hospital and they released me. I came home and then I started to have the chest pain.
So now it is the chest pain? Didn't the doctor tell you that you were fine and to go home and stop calling 911 before he had you arrested?
Why are you doing this to me? I wouldn't call you unless I was really having chest pain. It woke me up out of bed.
Are you fucking kidding me? You called in my 12-hour shift. What the fuck is wrong with you?
I am having chest pain. I could actually die. I don't deserve to be treated like this. Please help me.
Fine, we can go to Southside Hospital. Let's walk downstairs.
I can't go there. You know, Dr. Jones takes a set of vitals and tells me to get out. I could be having a heart attack. You all treat me so bad. I want to go to North End Hospital.
I'm sure you do. They aren't used to your bullshit and actually try to treat your hypochondriacs and phoas. Are you going to the hospital or not?
I told you I can't go to Southside Hospital. Why won't you listen to me? I'm going to pick up my expensive phone and call to complain to your supervisor.
If you want to go to North End Hospital, why don't you just call a taxi? They will take you anywhere you want to go.
I can't afford an expensive taxi. I spent all my money on weed and beer. And I ran out of my Xanax and am anxious.
Then how do you plan to pay for the ambulance ride?
I have state Medicaid. It gets me all the free ambulance rides I need.
So you'll be not paying for your dumb ass to go to the hospital. Okay, well then I'm not carrying you anywhere. You can walk.
But my legs hurt and I am too tired to walk. You should carry me down the stairs. Bill and Joe and Mark all carry me.
Wow, you know the names of the people that work here better than I do. I'm not Bill or Joe or Mark, not that any of them would carry you either. Are we going or not?
I am being mistreated. I am going to call your supervisor to complain.
That's great. You do that. I will be waiting downstairs in the ambulance. If you're not there in 5 minutes, we are leaving without you.
Alright, so I asked Paul if I could show that and to make sure that none of you would be offended by some of the language in that. And Paul said he actually had a call where a police officer did use some of that language in front of a patient. So even though it seems crazy that someone would say that, sometimes people do say inappropriate things.
And there actually are patients who truly are like that. That's
Anyone
the hard part.
Anyone ever experienced? Yeah. Have a lot of you had experiences with psychiatric patients? Are there a lot of you who are afraid of psychiatric patients?
So most of your experience has been here?
Okay, good. Good, because our main goal is just to help you feel a little more knowledgeable about the things you might see, and also know that you probably know what to do, and it's really not that different from what you already do with everyone else. Sometimes just the word psych makes people a little nervous. All right, so the first thing we want to make sure about is, and I guess we should say that we have these slides to guide us, but we certainly want to make this an interactive kind of thing. We don't want to be up here just presenting slides. So at any time, if anyone has a question, or if you think of a patient, or you think of something, please let us know, and we can break off from the slide and just discuss that. Okay? Safety is obviously and always the most important thing. We want to make sure that our personal safety and other people with us are safe. Realize that violence can occur anywhere. Position yourself between the client and an exit, something to think about, and gather as much information as possible about the client. Sometimes with some of these clients, you may not get the information you need from them, so you hopefully if they're with someone, a friend or a family member, you want to gather as much information from them about what's going on. Anything to add about that?
Okay, Sherry made all these slides.
The next, we need to make sure that there may be different things that are going on, and we want to figure out whether or not it's something that's emergent and we need to attend to right away, whether it's urgent but not an emergency and non-emergent. And so these are some of the things that you might see that break it into different categories. Obviously, suicide attempts, if they've actually done something, acute drug-related side effect, drug toxicity, violent, threatening behaviors, alcohol, which Paul said you all see a lot of, and unstable abnormal vital signs when you don't know what's really going on.
How many of you have seen suicide attempts? That's a lot of you. And have they been overdoses, cutting, a mix?
Urgent requires attention but may not be an emergency. These are things that you might still get called for, like that patient in the video. To them, it's an emergency, but you may assess the situation and realize that it may not be as emergent as the person thinks it is. So there may be things you can do to de-escalate or to assess whether or not this person has to go to the hospital or whether or not they have enough support where they're at. Or if they're seeing a psychiatrist or a counselor. And then non-emergent, you're probably not going to go for. Any questions, or has anyone had concerns about when you get to a situation, whether or not, as far as assessing the situation, whether or not differentiating between what it is?
I think a lot of times some of the calls I've gone on, the patient is pretty healthy, but they're in their mind just, they get sicker in their mind than they actually are.
Mhm.
Do you have any advice for dealing with that? Because I've gone on a lot of calls that the patient is fine and just they get all hyperventilating and you can't always just say, hey, take a deep breath, or our mind that their vitals are stable or something, but that doesn't always work.
And saying calm down. Doesn't work, right?
Yeah, exactly.
Okay.
Well, really, most of it is just spending, give my own opinion on that, is really sitting with a person long enough and being as calm as you can be and reassuring, and I know you probably do say, calm down, you're gonna be okay, and sometimes just doing vitals, well, even though you know the vitals are probably okay, just to reassure them, but just anything you can do to calm them down, try to get an idea of what upset them, try to get them sidetracked and talking about that a little bit. Sometimes simple little things like, listen, when's the last time you ate? Can I get you some water? Just any kind of compassion and comforting things you can say to them. Usually I find within 5 or 10 minutes, if they're not drugged out or something, most people are having panicky anxiety symptoms will calm down if you just sit with them long enough and stay calm enough yourself. You didn't have such luck?
No, we've had that before. I think you're right, just talking to them, getting them to
Yeah, most of it is talking to them calmly helps them along.
Yeah, they definitely pick up on how you're feeling it. So if you're feeling calm and you are feeling like in control and they sense that, they already are feeling better. And definitely they want to know that their vital signs are okay. So definitely share that information with them. Don't just take them and like look away, because if you don't share that information with them, they'll think something's wrong. So the more information you can give them, the better. And also letting them, empathizing, letting them know that, what you're going through must be really scary and must be really difficult for you, and I see you're having a hard time. So empathizing and letting them know that you understand how they're feeling. And then breathing techniques. I mean, the easiest of all is breathing. I mean, breathing, I always tell my patients that breathing is free. It's your best bet. It's always there. You don't have to worry about having it or not having it. And really teaching them how to do some deep breathing techniques. And doing it with them so they can understand that, because a lot of times they can't process what you're saying, but if you're doing the deep breathing, they can see what you're doing and they can breathe with you. And in doing that, and you probably all know this, that deep breathing is when you're doing it correctly and taking it in through your nose and then slowly out through your mouth and taking deeper breaths in when letting out, it sends more oxygenated blood throughout your system and it has a calming effect. So, if you don't feel strong in that, maybe, learning how to do deep breathing yourself or listening to some tapes that go through deep breathing can be one of your best tools.
The other thing I think to add to that a little bit is educating the patient, because usually when they're that worked up, you've probably seen kids with panic attacks, like they're truly experiencing chest pain, shortness of breath. And sometimes kids have not experienced that, and they come to school and it's their first panic attack, and it's scary. They think it's a heart attack. Now, we all know at your age, it's going to be rare. Not that it can't happen, but it's going to be rare. And just educating them about a panic attack so they know that can happen and they can get shortness of breath and chest pain, and those are all anxiety symptoms, and that just to learn more about what a panic attack is, to reassure them that that's all it is, that it'll pass. That can help too, just education.
Any other questions or comments about any of that? An appropriate environment. Again, you don't want to crowd someone who is having a hard time, so you don't want to get right in their face. You want to give them a little bit of space. Afford privacy. If they're in a big public area, a lot of people can get more and more anxious because they're afraid of what other people are thinking or what might happen. I mean, nowadays people will get out their phones and start taping someone, and it can be up on Facebook before you know it. So getting them into a private area or a private place where there's not a lot of other people. But don't risk your own safety. You wanna make sure someone else is there, and again, that you got that exit to the door, or there's other people who know where you are. Minimizing noise and then stimuli in the environment and dealing with the situation in a timely manner. So don't wait, because the more and more they escalate, the harder and harder it is to get them down. You had a story, and I thought it was really a pretty good one. As far as this whole affording privacy, but not at the risk of personal safety, when you had to go into a holding room with a patient.
Yeah, I probably err on the side of not always being so protective of myself. Because I've seen so many times when I was at the VA, for example, we would get a lot of really very, very agitated patients. Anything from severe post-traumatic stress disorder to lots of cocaine or whatever, drugs, alcohol. People would be out of their mind. And they'd put them in basically these locked rooms in the ER, and then they'd call the police down, and the police would all be standing out there with their guns, and the ER staff peeking in at them like they're caged animals, and I just thought that made the patients worse. And so I would go down there, and they're like, well, you can't go in there alone, you can't go in there alone. I said, no, I prefer to go in there alone. They're like, you're crazy if you're going there alone. And really, I think a lot of times, like for me, I found that having 4 policemen standing there when someone's already agitated and out of their mind tends to kind of threaten them and scare them more. So I just asked the police, I'm like, all right, you can stay close by, but can you at least go where you're not? They can't see you, and they think I'm in there alone with them. So I 99.9% of the time would go in by myself and ask other people just to stay out. And I found that to be, really in 20 years of doing that, a lot more effective than bringing other people in or you know, I never put myself between the exit and the door, whatever. I just try to find a way to have the patient feel like they're more safe. And luckily, I haven't been killed yet. But truly, it's always worked. In a matter of time, just you go in alone, and even though this says otherwise, keep the police as far back as you can, unless you're truly worried that someone's gonna, have a gun or something that truly could be violent. Most of the time, people aren't, and they want to be calmed down. They want to be reassured. They don't want 4 policemen standing there staring at them. So, anyway, I'm not the best in that regard about being safe, but it's worked for me so far.
And I think the important point is that different things are going to work in different situations. So you have to know what the situation is, and you have to also know your own skills and your own comfort level.
Yeah, a lot of it is your personality too. You know, what you feel comfortable with.
Clinical assessment. There's basically 4 things you do, and I'm sure that these are the things that you do with most of the people that you see. You want to find out what their chief complaint is and why they're seeking treatment. Mental status exam. Again, just what's their mood and affect. Are they congruent and going together, or are they not making sense? Are they talking normal? Are they not talking normal? Are they not talking at all? Are they having any hallucinations, any delusions that you can see? What's their concentration? Are they able to follow you when they talk, or are they looking around? Insight, how much do they know about what's going on? Are they reliable? And assessing impulsivity. You always want to include a suicidal and homicidal assessment. And then obviously you have to make differential diagnosis of medical nature, because sometimes people who present with what appears to be a psychiatric reason may have something underlying medical going on. So in most cases, to err on the side, you're going to probably have them go to the hospital to get blood work and to have all those things ruled out. Any questions about that? Makes sense, right? So depression emergencies. It's the most common psychiatric condition that's assessed in the ER. So if it's getting to the ER, that means you guys are probably seeing it also. They're obviously at high risk for suicide, not taking care of themselves. But again, we need to make sure that there's not something underlying going on. So we want to find out, again, just a quick evaluation. When did things start? How severe is it? How long has it been going on? Are they unable to get out of bed to go to classes? any other mood disturbances going on, recent stressors, losses, or lifestyle changes, presenting, assessing present and past coping skills. Are they at risk for suicide or homicidal? Ruling out anything else. Is there a substance-related problem going on? And then this just says, to meet a major depression, the person has to have been sad or depressed for 2 weeks period of time, and it reflects a problem in their functioning. I think the quickest, and there's 3 things, the thumb of rule with most things is asking what the chief complaint or what's going on means to the client, because you can't always assume that. I had recently someone who was suicidal because they had a breakup with a girlfriend. It seems like not a big deal to most people, but it was his first girlfriend, and it was his first breakup. So that puts a little bit different spin on it, and if I would just have assumed that it was just a breakup with a girlfriend, I might not have thought that it was that serious. So you need to find out what the stressors or what the symptoms mean for that person. The next thing, as it says here, is you want to find out if they have any coping skills. Have you been using any coping skills? Are there things that have worked for you in the past when you felt this way? And try to get them to figure out what they've used that's helped. And then, do they have anyone as far as a support system? Do they have friends that they've been talking to, or their friends that they can talk to, or their family members they can talk to? So in any given situation, if you can assess those 3 things, it's going to give you a better idea of what's going on and what you need to do. Physical exam, again, obviously the people might have decreased appetite and might have lost some weight. Sleep disturbance is usually an issue. Either they're not sleeping at all, or they're sleeping too much, or they have a combination of both of those things. Fatigue or loss of energy and decreased libido, energy, motivation, pleasure, drive. Psychomotor agitation or retardation. Sometimes when people are depressed, they say that they feel very slowed down. I had someone today in my office who said she just felt like a sack of potatoes. She just always felt like she was just there. But sometimes they feel this internal restlessness, which obviously is 2 very opposing things, and it's very confusing for them. Do they have hopelessness, worthlessness, reoccurrent thoughts of death or suicide? Usually your ability to think and concentrate is not good, and you want to find out if their symptoms have been so bad that they've been isolating and not doing what they socially usually do. Any questions about a physical or mental exam? You guys think you can pick out depression when you see it? So as far as what to do, again, medications are always going to be an option, but it's not an option for you. So you guys have to rely on yourselves and your psychosocial interventions. You want to make sure you're using an unhurried approach to establish rapport and assess the meaning of the situation and the stressors. Afford a supportive approach to convey warmth, empathy, and hope. I think when Dr. Armenta said, when's the last time you ate? Is there anything I can get you to drink? Those are some of the things that seem really simple, but that lets the person know that you're thinking about them and want to help them. Focus on their strengths and available support systems and resources. Provide health education regarding medication, depressive illnesses, and a treatment approach. For a lot of people, they may already be in treatment, they may see a psychiatrist, they may have PRN medications that they can take. So in a situation, even though you might not be able to give the medications to the patient, you can certainly say, are you on any medications? And is there something you could take right now to help calm you down? And that they could take themselves. Focus on their feelings and encourage them to talk. We all know that usually when we talk about what's going on, we feel a little bit better. What is the impact of their symptoms on their level of functioning, as we said before? And is there any potential for danger towards themselves or others? As most of you are aware, the only way that someone these days gets admitted to an inpatient psychiatric unit is if they are determined to be a danger to themselves or others. And when we talk about a danger to self, we can think about a suicide attempt, but we can also think about other people who maybe are not eating and have lost a lot of weight. or people who are not able to get out of bed and are not taking care of themselves. Those can be classified as a danger to themselves, or they're not taking their medications the way they're supposed to, or not taking them at all. And sometimes even people we think should be admitted aren't. So, it's never your call, and I would, again, always err on the side of taking them there and getting them evaluated. Any questions about that stuff? Yeah?
About like people who practice self-harm, because I know that, like, I've been on a call where it was, a young woman practicing self-harm that the RAs interpreted as a suicide attempt. What kind of, like, approach would you take to that?
We do have some slides later about that, but we can address it now. I mean, I think that's the thing you have to figure out. You need to ask the person right out, you know, did you do this because you wanted to die, or is this something that you do because it brings you relief? For most of them, self-harm is a way, it's one of their ways that if they're unable to feel emotional pain, that they can feel the physical pain, and it's a release for them. The other problem with it is physically when someone does that, if you think about the whole biology of it, if they draw blood, then you've got all the thrombin and prothrombin rushing down there to take care of it, and it actually does give them a release and a sense of calmness. So it becomes a very addictive behavior. So I think the best way to differentiate is to ask them straight out and not be afraid.
Yeah, and I would ask, find out when the cutting started. You're primarily cutting behaviors, you mean?
Yeah, I mean, that's just a situation.
Yeah, there's a lot of that goes on here, and I think that you'll find out most of the time if you're, there are some that just first time they get here, they're 18, this is a new experience, they're overwhelmed, and that's the way they deal with it. But you'll find out most of the time the cutting behavior started in early adolescence. And so I would just ask the history of the cutting behaviors, ask if they ever accidentally, you know, like Sherry said, you want to know, did you do this to release pain, or are you feeling suicidal? Usually it's not because they're suicidal. Usually it is a way of releasing emotional pain. But I would ask, again, when did it start? And have you ever accidentally cut so deep that you did end up having to go to an ER and get stitched up? Most of them don't. It can happen. I'm not saying, you know, don't take it seriously. You have to always take it very seriously. But most of them know like just how far to go without really injuring themselves. But you're going to base that on what you see and their history and how they say they're feeling at the time.
I actually had a patient this week in my office, and she had not been cutting for a very long time because she had a very specific, she called tool that she used to cut herself. And she, as part of her treatment plan, had locked that away and didn't bring it to school, so she had been unable to cut because nothing else worked. And she said she went through her room because she was very upset. The boy she'd been dating was dating someone else, and she had found out. She was very, very upset, and she went through her room and gathered up all the knives, and she said she used the knives against her skin, and they were all very dull, and they just weren't going to do it. And she was just sitting there, and she looked over and saw the stapler. So she went over and said to herself, if the staple comes out when I punch it, then it means that I'm supposed to use this. And one did, and she started using a staple to scratch herself. And she said that for her, as far as what Wendy said about knowing when to stop, she always self-abuses in the same location on her leg, where it's usually not something that someone can see. And she will do it in, it's almost a very kind of meditated, kind of relaxing thing. She does it in a certain movement. And she said this time she was going in a different movement, which was very weird. And she went off where she usually cuts herself. And when she drew pain, she didn't even draw blood, but she drew pain, and it felt different. And that for her was enough to know to stop. So, I mean, it's okay to talk to these people about what it means to them and to let them describe what's going on for them, because I think that brings relief, again, knowing that, you know, here's someone who is trying to understand what I do and helping me understand it. And the whole part about educating someone as far as self-abuse, that it can become addictive, and it's because of the biology of how it works, and yes, it is very hard to stop. Sometimes when people understand that, that also brings relief to know that. but then obviously you have to help them come up with other coping skills, which at that point is not your job. But some of the things you could use, if they're actively engaged in that and still feel like they need to do something, if you have an ice cube, going and getting an ice cube and holding it in their hand is something that some people have said also kind of feels like pain and is cold and it's a sensation and it can stop the behavior. Or giving them a rubber band and snapping it. It certainly still is causing a little self-abuse by doing that if you do it enough, but it's better than the cutting.
Or any of you on Sunday, I know a student here cut themselves Sunday night and ended up going to the ER. None of you? You were on Sunday?
Yeah.
Yeah. So, but rarely those patients, it's very rare they're admitted. They go to the ER, then they send them over to CPAP, and doctors at CPAP ask the questions, like I said, well, do you do this all the time, are you trying to kill yourself? And once they say no, they don't admit them, and most of those patients need long-term
The
therapy.
first thing the nurse asks is regular and
Pardon me?
the first thing the nurse asks, is it regular or?
Yeah,
Something.
yeah.
Yes?
I've never been on a self-harm or suicide call, so I don't know if this is something that anyone else can answer. But if we arrive on scene and there is someone who obviously practiced self-harm, but they don't have any suicidal thoughts or feelings, and their damage isn't enough to warrant a ride to the hospital and they don't want to go, would you recommend calling the on-duty psychologist or the on-duty psychologist for the school? Or I don't know if I'd feel comfortable ever leaving someone if I found them. Like, what would you recommend?
That's a good idea to call. Yeah, there is always somebody on call. So I would make the call. A lot of the patients probably already are connected, or the students already are connected, but not all of them. And so I'd ask for sure the patient or the student if they're connected with a therapist. But either way, I would call the on-call person and just let them know. Either if they are in treatment, they will then relay that message on the next morning, whatever, to the person's therapist. Or if they're not, they'll reach out, or they, or student affairs can reach out to the student and get them hooked up with the therapist or one of us.
Okay.
But yeah, that's a really good idea to make a call.
I think it was early last semester, we had a case where somebody just they called EMS. Really all they wanted was to talk to their therapist or a therapist from the counseling center. So our crew got into a little bit of situation where we obviously can't transport to a hospital because they don't want to go to the hospital. They weren't suicidal, they just wanted to talk to a therapist. So what we found out is the therapist will come in, whoever's on call, but their counseling center's protocol is they will meet them only at DPS. That way there's somebody else there. They don't open up the counseling center. So what we've figured out is the best way to solve that problem is you would stand by with the person in the ambulance until that therapist gets to DPS. Because DPS won't be responsible for them either until the therapist is there. And then at that point, have medical transport come get the person, you do your refusal, medical transport drives them to DPS to be seen there. You know, it's a kind of a roundabout way to make the person avoid an ER visit, but it works, so.
So the therapists always come in, they don't just talk to them on the phone?
This one, the student, and we're willing to come in and talk to them, to get them to calm down. So,
All right. Obviously with depression, we said one of the issues that arises is that most suicidal behaviors, the person usually has a depressive episode, has depression. Some of the acute risk factors, it's actually more males than females that have suicidal behaviors, usually older than 45. Although some other research shows that 18 to 24 is also a very high population.
Yeah, in the last few years, it used to be about out every year.
White, living alone, obviously, and if they have some chronic medical conditions, mental or other emotional disorders. So those are some things that put people at risk factors. Predictability, someone, sometimes they will talk directly or indirectly within the last 6 months. previous suicide attempts. If it's already something in their kind of coping skills bag, whether or not it's, you know, something that works or not, they're more likely to do it. If they have family members who've used it, they're more likely to use it. This one was interesting. They've consulted with a physician within a month. And I actually do know of a situation where someone had seen the physician on a Friday and suicided the next day. And then another instance where a person went to their primary care and didn't talk about being depressed, didn't talk about any suicidal ideation, but actually had gone to the physician's office complaining of some other physical things, and then suicided 2 days later. So, you know, again, as Wendy said, for the most part, they usually are trying to reach out and the best way they can communicate how they're feeling, and sometimes they just don't have put words to it. People with major depression, bipolar, alcohol or substance abuse, schizophrenia, anxiety, and personality disorders obviously are more at risk for suicidal. All right, this is a lot, but I think it's important stuff. Suicide is very important, or very personal, so you want to ask direct questions. Let them know, again, when it says general to specific, I know you're having a hard time. It seems like you're having a difficult time, to help them understand that you're trying to understand how they feel, and then get them to talk more specifically about what's going on. Obviously, you want to try to use a non-judgmental and supportive approach. Try to establish a rapport. Use a suicidal risk assessment that asks, do they have a plan? Is it just ideation or is it a plan? Ideation can sometimes lead to a plan, but it doesn't necessarily always mean that. We have a lot of patients we see, and I call it passive suicidal ideation, where it's not even really that they want to kill themselves, they just sometimes feel like they'd be better off dead because they're in so much pain, and anything would be better than the way they're feeling. And then they usually go on, if you ask them that, to say, I don't think I could ever do anything. So it's important to know, with even the ideation, is it something that's really active and that's leading to a plan, or is it just they're in so much pain they just want it to stop?
And I would ask specifics about the ideation too, like how would you do it? You're thinking about it, how, because sometimes in the world they say, well, yeah, I'm thinking about it, but really I didn't really think about which way. But then you'll find people who've like researched every method, they know exactly how many milligrams of X, Y, Z to take, or how to do carbon monoxide poisoning. And if they know more details and have researched more methods, of course, that's scarier when that person says, no, I think about it, but they've never really looked into it. So ask them.
Ask about suicide does not put the idea in their head. So a lot of times people think, I don't want to ask about it because I don't want to give them any ideas. It's already there. It's better, and it's always more of a relief if you can talk to them about it. Assess their level of hopelessness. That oftentimes can help you realize how serious it is and where they're coming from. Know your own reactions to suicide. There was an example when I was researching some of this online where the clinician said, you're not suicidal, are you? I mean, right then it shows that you don't want them to be suicidal, and it's not something you're really comfortable with. So you're more likely to get a no answer with a statement like that. Saying, are you suicidal? Shows that you're open and you want to hear more about that, and you're okay with it. Any questions about before someone does anything? Because the next questions are a little bit about after they've had the attempt.
Although I think this one isn't what they could mention. Just to avoid using religion or guilting them and say, how can you do that, that's selfish. Think about how that would make your family feel, or this or that. Really, when people are that bad, they're at the point, or they've already thought about that and they don't care. So kind of guilting them into not doing it really isn't effective. Or saying, you don't know what happens, suicide, God makes you go to hell if you kill yourself. Not a good idea either.
But if they're telling you they feel like they would be in less pain, you can always present them with the possibility that maybe they wouldn't. So to get them thinking and trying to distract, maybe you wouldn't be in less pain, who knows? I mean, who's really literally come back after dying and said that you're in less pain, maybe you are in more pain. So just presenting an alternate thought or another possibility to what they might be thinking it's gonna solve for them. Evaluating a suicide attempt, you wanna find out what the circumstances were, what methods were used, what they hoped to get out of it. Was it impulsive or was it planned? And was the client sober or under the influence of drugs? Usually if someone is more serious or they have completed the act, it's usually something that's a lot more impulsive. And there's been alcohol and they've been under the influence of drugs, because they're not thinking clearly. Any questions about that? All right. We want to triage immediate danger and whether or not we have to intervene. Stabilize any current or potential medical conditions, so you're all good with that. On the scene as far as ABCs. Provide adequate client safety, confine and restrain. You guys obviously cannot restrain. Remove dangerous objects, Paul. I mean,
You mean like this?
it usually says, I mean, you're probably not gonna wanna get into it, so if someone has something and they're doing something, I probably would get back up. Unless you have,
DPS is traditionally on the scene, we're just,
okay,
we're gonna let them handle it, and
okay.
physical altercation is about to take place, and we'll pick up the pieces after.
Take all suicidal threats seriously, we talked about that. And recognize clients who exhibit a sudden change in their level of energy, follow about with depression. So that, sometimes you hear about, and patients even come to us and say, you know, I really don't want to take an antidepressant because I heard it makes me suicidal. And it's not really that the antidepressants make them suicidal, but what happens is the antidepressants start to help them feel better and give them more energy. And they have more motivation, so that they're more likely to carry any plans out they might have had. So a lot of people say that there was no warning signs, they seem to be getting better, their depression is getting better, how could this happen? Oftentimes that's what's going on. Yep.
I thought that was interesting, I read something and it was, so they're so depressed that they don't even have the energy to follow
Right.
through the suicide.
Yep.
So you start taking medicine and you actually feel good enough to, hey, today's the day. I mean, it's amazing how the brain works.
And I think the important thing for us as prescribers is that when we see someone who has had a high level of suicidality, and we do all these things too, we're assessing them constantly to see what it means for them, or if they've done it before, or if it's in their repertoire. We follow them closely, because obviously, you know, a lot of the psychiatric medications don't kick in for 2 to 3 weeks. So you don't want to just give someone these medications and leave them out there for a month. You want to bring them back in a week. You want to bring them back in 2 weeks, because this is the sort of thing that we have to keep our eye on. And that's where sometimes people who are prescribing medications fail, because they don't monitor them as closely as they should.
So I hope I'm not jumping the gun on this, but, you know, most of the psychiatric emergencies that I've dealt with, you know, tend to be chest pain, and maybe you don't want to talk about it, like, how can we get this health service involved with these people without, like, because we're just gonna be going to a hospital generally, but is there some way to, like, you know, 9 o'clock at night, 2:30 in the morning, get a phone call to you guys, or start some, is there any plan for us to actually initiate that sort of thing?
I mean, if they're, I would say if they're already hooked up with the counseling center, and really all they want to do is talk to somebody, if, you know, if they haven't threatened suicide, they haven't harmed themselves, if they just need somebody to talk to, that would be the place to start. I mean, right now, so every PCR that is generated since we went electronic is reviewed by Dr. Zetzis, the medical director. So he's obviously aware of the issues. Just recently we transferred somebody that was threatening suicide. So he saw that, flagged it, he knows to look for it, when that person comes to the line, or to at least try to make some recommendations to get them some more advanced help.
So pretty much that's where we help Or if it gets caught and hit
Right.
with us.
You
Well,
know,
I mean, you could-
Worst case, they're just going to, so they're gonna get help.
And you can certainly refer them to clinical counseling if they're not with clinical counseling. The way Wendy and I get referrals are, they have to be referred either through the health service center and Dr. Zetz's, or they come through clinical counseling, saying that they need a psychiatric evaluation. And there is a 24-hour line through clinical counseling, and there's also a 24-hour line through health services. I think Wendy's 2 or 3 down the line if they get a phone call at health services that has to do with psychiatry. So she would be available if it's a medication question. But usually at this point, when you guys are intervening, it's more of, again, that psychosocial interaction, and the counseling center is going to be your best hope.
So predominantly, we're gonna end up with CPAP at St. Joe's with that patient. And that's where the process will start. Alright, so basically, you did jump ahead, but it was a nice intro into this. What does that mean as far as what you guys do and sending them elsewhere? You need to assess the client's present level and future potential for suicidality and their ability to control it. So do you feel safe leaving this, not doing anything with this person because they do have friends that they're staying with, or they have family in the area, and they're saying that they feel much better and they're gonna call their therapist in the morning? You need to look at the external controls and available support systems. What is their perception of the client's suicidal risk and its likelihood in the future? So again, if they had done it before, are they likely to do it again? Chances are yes. You want to use your crisis interventions, which you've already talked about. And if you can, if you can precipitate, the precipitant is clearly identified, and they have quality support, and they have a high level of function, and they already have somewhere they can go to, then it may be that you feel comfortable with just telling them to call the counseling center or call their therapist. Schizophrenia and other psychotic disorders. Anyone? Anyone see any schizophrenia or psychotic disorders? Thank God. Yes. Yeah.
A friend of mine's brother was schizophrenic and wasn't being treated because he was over 18 and couldn't go to, wasn't able to be admitted or kept in the hospital because the police deemed he wasn't a threat to themselves. But, he would just talk to himself all the time and was extremely violent and very manipulative, and so he could lie to get out of help as well. So I don't know what to do in that situation because whenever they tried to restrain, keep him in the hospital let him go because he was manipulative.
But he had a history of true violence toward others?
Yeah, he would, smash things, hurt them, scream and stuff.
Would he hurt other people or just
He would attempt to hurt them. But they didn't, the police and the hospital were also kind of not believing it because they thought it might be drugs too. So.
Yeah, it's actually very difficult. And New York State has very strict laws. I can't tell you how many times I have patients who, very similar, agitated, hallucinating, threatening words, threatening gestures, whatever, weren't hospitalized, and then sometimes they're hospitalized against their will. However, they have rights, and they can petition, if they're hospitalized, they can petition, you're saying the hospital will let them go, but the patients can also say, I don't want to be here, and they can request discharge, and you have basically up to 72 hours to petition the court. And then I have had go to court a number of times to say, listen, I think this person needs to stay in the hospital because I think they're a potential danger to themselves or others. And that's variable too, it depends on the judge. Some judges will, if you're the psychiatrist and you're there and you're saying they're a potential danger, they'll just be like, okay, you get 60 days. But I've had judges who have said, can you prove to me that this person is an imminent danger, which really is the law, that they're an imminent danger. It doesn't matter that 4 months ago they beat someone up. I have to be able to prove, and that's really hard to prove. How do I don't have a crystal ball. You can say, I think it's highly likely based on their history, but you can't really prove it. And some judges are really that strict. And the same thing kind of happens with hospitals, because patients have rights and hospitals want to get people moving out, so if people are able to lie, they're lying, you can't always do something about that. If they're saying I'm not a danger, and there's not other family or other sources to say, yeah, they are, we know this because of X, Y, and Z. A lot of patients get out who are still potentially dangerous because they do manipulate the system and can
I
only
think
do
a
so
lot of
much
it
about
is
that.
like they're easy to blame the drugs on it too, because a lot of schizophrenic use drugs.
A lot of psychiatric patients use drugs, a lot of people use drugs. Yes, true, a lot of SU students do. Yes, not in review. But yes, when drugs are involved, it's always more complicated, and it makes people more violent.
And I heard someone over here, like, when Wendy said 60 days, we were like, wow.
Seems like a long time.
It is a long time, and I think when Wendy was
So is
talking
that-
about that, she's talking about the VA system, you tend to be able, I don't know, I mean, I know when I worked at Benjamin Rush, it was an acute hospitalization. When I started, it was 3 weeks was an average stay, and by the time I left after 3.5 years, we were down to 7 days.
Oh, yeah, the
So
average.
60 days, that's not, is that time that you as a psychiatrist can deem whatever you
Yes.
see fit to do? So if they have to be committed for 60 days, you can.
Yes, you
Or
can.
you could pull them out, whatever.
You can commit them for 60 days, if they get better in 6, you can let them go. If after 60 days, you're still concerned about them, you have to re-petition the court for, they'll typically give you 60 more days. And that's happened, I've seen people, because people refuse meds, then you have to go back to court and petition for treatment under objection, which is different than, than just keeping them in the hospital, so patients can refuse all kinds of things. And a lot of them do.
Yeah.
A lot more than you realize actually do refuse, especially psychotic patients, because often they don't have insight into their illness, or they're just paranoid. They're scared to death the drugs are gonna poison them, kill them, so they'll refuse, and you have to go back to court and get a judge to give you authorization to treat them against their will. Which isn't fun, because a lot of times you have to give them shots, and nobody likes to do that, but most of the time, again, it's been rare that I've had to do that over the years. I think you would just sit with the patient and tell them this is where we're at. Even if they're psychotic, there's some part of them that can sense whether you mean well. And very often we say, we have to medicate you, we're concerned enough about you, and these are the options. We can give you a shot, or we can give you this by mouth, which is obviously going to be more